Hi, I am Dr. Lourens Coetzee, a refractive surgeon at Sandton Eye Clinic.
And I'm Dr. Yolandie. I am a general practitioner with a passion for medical education. And we wanted to make a nice video today for those of you who are diagnosed with keratoconus, but I have no idea what it is and what to do about it.
So keratoconus, it's quite a common problem, as I can say, or patients presenting to our practice with keratoconus are quite prevalent. And that's not because there's so many patients out there with keratoconus. It's just we pick these patients up when we do screening to see whether they are candidates for laser vision correction. But on the other hand, we're also a referral clinic for patients with keratoconus. And people don't know much, and people don't know much about keratoconus out there. So let's start. Let's get the word out on what is keratoconus, how do we diagnose it, and then most importantly, how do we treat it.
So just the basics about what keratoconus is. So basically, the front window of your eye, your cornea, needs to be nice and round to refract the light so that you can form a clear picture at the back of your eye. And what happens with keratoconus is that the clear window, the cornea of the eye, gets weak and bulges out in a cone shape, which then causes a distorted or unclear picture in the eye.
Yeah, so often, like you'll find optometrists when they test your eyes, they say that you've got a racquetball shaped eye. So the analogy I like to use is that you do have a racquetball shaped eye, but this racquetball is a skew racquetball, so it's pointed towards one specific point. And what you will experience is when you look at these e-charts, these letters on the board, there will always be like a little shadow. It will be like a double image or a double E or a double A. And that is because there's multiple focal points produced at the back of the eye. I know Yolandie is the big health educator, so she can explain it much better than I can. Yeah, and that's why she's here.
Yeah, so most of these patients are diagnosed in their late teens and early 20s. And uh, then the visual symptoms get worse over a period of about 10 years. And then after that, it usually stabilizes. So it's good to catch it early and treat the patients before the vision gets worse.
So there's a slight, I don't know if you can call it a caveat or um, a slight twist here, and that is in sub-Saharan Africa and the warmer climates, it's quite prevalent. And what we've seen in South Africa is that uh, it is diagnosed at a much younger age, or it presents at a much younger age. So where it normally starts as a teenager, when you go into puberty, and then with this growth spurt, the keratoconus also accelerate. We actually see it in young kids, 8, 9, 10 years of age, which is quite different than to the rest of the world. And it has much to do with with the high prevalence of allergic conjunctivitis, especially in the warmer climates, where these young kids, they just rub their eyes. And I think that brings us to our next common question that patients ask us is that why do I get keratoconus?
So as Lourens said, it's seen more often in warmer climates, which is the issue in our area. And it's often difficult for doctors to admit, but it's difficult to say why. We don't really know exactly why you get keratoconus. So it's actually a combination of possible causes, and maybe Lourens can explain it a bit more.
Yeah. So the thing is, we have this two-heat theory. So you are born with this predisposition in your genetic material. So we find it runs in families, and we'll come to the screening of keratoconus. So just hold that thought. So you do have the genetic predisposition for it, but you need a second insult. So either you are an eye rubber, or you sleep on your eyes, or that's why we do the screening is when we perform laser vision correction or any type of surgery or trauma to the eye, mechanical trauma to the eye can initiate or accelerate keratoconus.
So, should your family get tested if you have keratoconus?
Yeah, so in my practice, when we take a history from our patients, one of the questions that I always ask is, do your your parents, like, are they wearing hard contact lenses? Your grandma, someone in the family, uncle, aunt, have any of them had corneal transplants? And because yes, it runs in families, as we've said, and it's important, like from my point of view, that if one are aware that you have keratoconus, that your siblings and your offspring, the children, should actually get tested. And the next question is, when should they get tested? Because we know mostly it starts in the teenage years, but in South Africa or in sub-Saharan Africa, we see it at a younger, at a much younger age. So, as with all children, when they reach the age of 4, they should have a good, decent optometric exam. So you go to your optometrist, and they will test your eyes, and they will have a good idea of whether you have a refractive error. So if they test and they feel that you need glasses, there's two things that you should look out for. If your child rubs his eyes like quite often, and they have astigmatism, so you can ask your optometrist, like, do my kid have astigmatism? Then I feel they should be assessed by an ophthalmologist, or at least have topography. And if your optometrist has the means and ways of doing topography, that's like a scan of the cornea, that clear we know of the eye, then I think that will be sufficient. But if not, then go and see an ophthalmologist that can see whether your child does have keratoconus. But not only that, like, you need a baseline, and if there's a change, like a jump in your refraction, your spectacle reading, let's say more than 1 diopter, we say normally in a year's time, or that astigmatism is getting more, at least there's a baseline, there's a test or a scan to refer back to, where and then it's much easier to even pick up the smallest, slightest deviation or tendency towards keratoconus, and we can then address that sufficiently.
Going a bit further in the topic of testing your eyes, what scans and tests are performed at an ophthalmologist for keratoconus?
Okay, so when we test, so I want to approach it a little bit differently. I would like to say, when we do laser vision correction, what type of test do we do to actually determine whether a patient is a candidate? In other words, that the patient does not have keratoconus. And the mainstay is a corneal scan, or a scan of that clear cornea, or the clear window in front of the eye. It is called corneal tomography. So tomography is where we look at the front and the back surface of this cornea, and normally you'll see a display on the doctor's computer screen. There will be like 4 maps, and the one will look at how steep the cornea is. Then there's a next little image, how thick the cornea is, are there any protrusions from the back, and the last one that we normally look at is all the various layers, especially the outer layer of the cornea. And in essence, if you see like a red hot spot on any of those scans, that normally points towards an abnormality or an elevation or a very steep area. It's normally at the bottom and towards the nose side. So if you look at that round little circle and you see at the bottom towards the side, there's a little red spot, especially on the little image that shows us elevation or protrusion from the back and the steepness of the cornea, then that normally points towards keratoconus. But there's also some algorithms that we then run through, because often it is not that obvious, especially if the keratoconus is of a low grade, and we're going to come and talk about the grading now. But if the keratoconus is very subtle, Then we need special algorithms. We even employ AI, and it actually tells us what is the possibility, what is the chance of this patient having keratoconus. So there will never be a definite yes or no unless it's very pronounced, but often it will tell us, there's like an index, and will tell the likelihood of this person having keratoconus is quite high, and it's always important to err on the side of safety. And if we think that the patient might have keratoconus, we will not perform any laser intervention like for correction, and we'll rather follow the patient up.
And then if we get to treatment options for keratoconus, I think it's so often your optometrist will first give you glasses, and they will see that your maybe your prescription changes a lot, more than one diopter in a year, and then they will definitely consider referring you to a refractive surgeon. But the other thing that they also often can do for you is help you with hard or scleral contact lenses, which can help with the unevenness of the cornea. So we'll get an optometrist in another video to give us all the information about scleral contact lenses. But how it basically works is it's a contact lens that covers the whole front part of the eye, and has a water interface in between, which then helps refract the light nicely so it falls on one spot at the back of your eye, and it doesn't scatter and make multiple shadow images. So that's what your optometrist will probably do. But then after that, if they refer you to a refractive surgeon, there are other treatment options that are based on how severe keratoconus is, and it's very individualized. So it's quite complex to tell you that you will need this and that treatment. They always have to look at your specific eye and decide on treatment, and even your two eyes can differ quite a lot. So Lourens can tell us more about the treatment options for keratoconus, and what the refractive surgeons normally, all the options they would consider and combinations of them.
So I think which is very, very important is before we start talking about how we're going to make you see better, is that keratoconus is a progressive disease. So regardless of whether the optometrist is going to give you spectacles, whether they're going to give you scleral lenses, or whether we're going to perform surgery on your eye, we need to determine is your keratoconus progressing. Okay, and almost in all children and in teenagers, if they're diagnosed with keratoconus, the chances are highly likely, or there's a high likelihood that they will be progressing, and we need to address that first, because there's no sense in giving a patient like perfect vision and the vision just keeps on deteriorating. So we talk about cross-linking, and that's our first step. And if we, so there's different protocols and there's different ways that people address progressing, like or stop progressing in children, or let me say the indications for cross-linking. But in our practice, what we say is that any kid or teenager younger than the age or younger than 20 years of age with confirmed keratoconus, they will get cross-linking. And then any person older than 20 years of age that is actually progression or shows progression on their tomography, the keratoconus is getting worse and there's evidence of that, they will also undergo cross-linking. And so what is cross-linking? Cross-linking is where we use a UV light and we combine it with vitamin B drops, and it's a procedure that gets done in the practice, in the doctor's office. It takes about 20 minutes, and the combination of the two hardens the cornea. So we just give some tensile stability or strength into the cornea and prevent this protrusion or conical formation from progressing in the cornea. So other general examples of that is if you go for your nails, the ladies, You put your nails in that little UV oven, and they harden the polish, nail polish. Or if you go to a dentist and they actually use like a UV light to harden the filling in your tooth. So that is the most important part of managing keratoconus. Then, as Yolandie said, is that the mainstay of treatment, if possible, is glasses. If you don't see well with your glasses, so let's say your keratoconus has progressed quite a bit, and you don't get clear vision even with glasses, then they can either fit you with spherical contact lenses, hard contact lenses. There's so many types of contact lenses that they can help you with, but what is important is that soft contact lenses usually is not going to be sufficient in this in at this stage of the disease. And then we have patients that are just not tolerant. They've to these contact lenses. They've tried spherical contact lenses. They've tried hard contact lenses. It really makes their life difficult. They can't see clearly. They are really intolerant to spherical contact lenses. Then those patients come to us, and we can actually help them. We also have patients where spherical lenses, they can fit it, but it's impossible with their lifestyle to actually use it regularly. And in those patients, we can then also consider a surgical route of treatment of keratoconus. So when a patient comes to see me with keratoconus, and then the first thing we do is we stage it, and there's 4 stages, and stage 1 to 4, and I'm not going to bore you with the details there, but it basically boils down to how well this patient can see with his glasses, and whether the disease is stable, is the keratoconus stabilized. If the patient can see well with glasses, and then we just make sure the condition is stable, then we can consider a procedure like implantable contact lens. So implantable contact lens basically um, like it basically takes or functions as glasses, so it performs the same function as glasses, but it's a permanent lens that you implant in the eye. You don't see it, you don't feel it. It takes about 30 minutes. It is safe, and a good follow-up is needed, of course. And with that lens, you have spectacle independence. And probably we'll have another like session and talk just about these implantable contact lenses. What is important is that if the patient does not have good vision with his glasses, then the implantable contact lens will not work for that patient, and further treatment is necessary. And the reason why glasses don't work is normally the cornea, or that front window, is so irregular and so pointy that the glasses are unable to correct or to focus a clear image at the back of the retina. And that's why, as Yolandie said, a spherical lens works so well, because it gives you a nice smooth optical surface. And on this point is that the vision that you can get surgically is going to be excellent, but it's not going to be as good as a scleral lens. So that's why our first option will always be a scleral lens. Just go for a scleral lens fitting and see if you don't manage with that. So now we've determined that let's say you sit here and we test you, and with your glasses you can't see well, and you can't get a nice clear image, a clear 20/20 or 6/6 vision, even with correction or with glasses. What would be our next step? So as I've said, we're going to focus then on the cornea, and depending on the degree of irregularity, one can either do limited resurfacing of the cornea, and that we use laser, or we can use a corneal ring. So in the past we used plastic corneal rings, but something which is very new, relatively new, and then it's not like like hot off the press now, but it's been around for about 2-3 years, is where we use not a plastic ring, but we use a a corneal tissue ring. So it is a ring that's created from corneal donor tissue. So someone they've passed away and they've donated their corneas, and then they create the little rings from that cornea. So this has been a game changer in our practice, in the sense that we don't have the complications that we saw with the ring and with the plastic rings. And the aim of these corneal rings is to just regularize the cornea. So we want to create a very nice corneal surface, front surface, and that is regularized, and so that we can use our implantable contact lens. Sometimes you still need to do a little bit of resurfacing, and after that resurfacing is done, then we can do the implantable contact lens. Now we need to just state here that this is a very long process. So it can take anything between 1 and 2 years, and with multiple procedures, especially the more advanced the keratoconus has progressed. So typically, if someone with keratoconus comes here with their glasses, they can't even see the second or the third line. What we will then do is the first thing we will determine is this stable? Is this condition stable? And then we'll start with the various procedures. So first step is we'll do the corneal ring, and then we will come after we've done the corneal ring. We might do a little bit of surface or resurfacing with the laser, and that's 3 months later. Then we'll do cross-linking, or just to strengthen the cornea after we have resurfaced it. That's another 3 months later, and then after the cross-linking, we've waited another 3 months, then we'll do the implantable contact lens. And we do one eye at a time. So here you can see it's a very long journey, multiple procedures, but patients do reap the rewards. They do, like, these patients are often so grateful and so thankful, because all their lives they've been they wanted to have laser, or they want to go off their glasses, or even off their contact lens, because they couldn't see well with their glasses, and they were told, no, we cannot have, like the only option that we have for you is either a corneal transplant or scleral contact lenses or hard contact lenses. These patients are desperate and for help, and we are able to help them. They just need to be patient, and it takes quite a while for them to reach the vision that we and the patient are satisfied with.
Next question that everybody asks is, am I going to have a corneal transplant eventually, or maybe not?
Okay. Yeah, so, yeah, and I think because there's a shift in the management of keratoconus the past 3 years, and there's been some confusion here. So in the past, before we had cross-linking, if a patient started to progress and we see that they are progressing, we will often tell them eventually you will need a corneal transplant, because rings didn't stop progression, scleral contact lens did not stop progression. The only thing that stopped progression, twofold, is cross-linking and stop rubbing your eyes or sleeping on your eyes. Those are the two components that actually stop the progression of keratoconus. So the shift has now moved towards doing cross-linking early, but we still do corneal transplants in some patients. So let's say we see you and the keratoconus are really advanced. We talk about grade 4. The cornea is very thin. It has already scarred. Often we talk about hydrops. So the cornea was bulging so much that a small rip formed, or tear formed in the inner layer of the cornea, and then you get swelling and scar formation, or it's so steep that you can't even fit a normal scale contact lens. And we also see that there's no tissue to resurface or to ablate. Like a ring is not going to do much. In those patients, we have to do a corneal transplant. And it's not always that we have to do a full thickness transplant. I think as long as there's no scar or that inner layer hasn't torn or ripped, we can actually do a partial transplant. And with the partial corneal transplants, we found that it lasts much longer. Your risks are much lower for rejection. And once we've done the corneal transplant, uh, you, and you've gone through your whole year of suture removal, because the sutures need to stay in the cornea for a year, one can start with the visual rehabilitation, where we do a bit of resurfacing. We might do implantable contact lens or a lens replacement. So also, just remember that when we do a corneal transplant, it is not a one-stop solution and your problems are sorted. It is just, we're just giving you tissue to work with. We still have to do work after that to give you decent vision with glasses.